All right, well, it's the top of the hour. Good morning, everyone, and welcome back to Grand Rounds live in person from Minneapolis. And it's a real pleasure to see all of you here in the room. And for those of you who are joined virtually, thank you for being a part of this morning, and certainly look forward to all of you being back in person really soon. So I have the pleasure of sharing this Grand Rounds with John Zakaib. And just to make sure that there's no confusion about who we are and why you're here, we're not the old John and Paul. We're the new John and Paul. You know, the haircuts were an attempt. The ties, I think, John, you got the wrong color there, but you know, we're pretty not too bad, not too far off. But you know, it's really exciting, and what's really fun is that this is the first time we're giving a presentation together. So it's actually our worldwide debut, and you're here for it to witness greatness in the making. You know, so in the spirit of the old John and Paul, we are going to be talking about something that's, I think, revolutionary, and that is TR. I'm going to start with an overview of TR, the devices, and kind of give you a taste of what the science is in terms of where we think we're going to go. And then John is going to come in and talk about TR leads and what they're doing to make things even better in the future. So I'll go ahead and get started here. So when we think about TR, you know, it's often been described as this forgotten valve, and there are so many reasons why it's been neglected, and we could list probably hundreds here if we wanted to, but there are three common themes that I would ask you to consider. So, you know, the TR patients, they're often survivors of other cardiovascular disease. It's often TR after aortic or mitral surgery, or TR in the setting of chronic HFpEF. It's kind of this afterthought when it comes to disease and such. And as a result, it can often fly under the radar with this kind of long indolent period in which we can manage patients with diuretics, and they can kind of get by. And what we've learned is that the RV is actually a late indicator. So from really good CT analysis, John Lesser is involved in that. We know that the effect of the RV is actually a late issue. So severe TR can fly under the radar for so long. And then we also know that the severity of TR is really easy to underestimate. You know, if we just look at the color, it's going to look relatively unimpressive when we compare it to the left side, because the right-sided pressures and the momentum on that side is much less than the left. So we have to really get more sophisticated, and that severity can be easily underestimated. And that neglect of TR and the science behind TR has actually led to a complete paucity of indications as to when and how to treat these patients. When we look at the valve guidelines that came out a couple years now, there's only one class 1 indication for TR intervention, and that's when the TR is severe and the patient's undergoing left-sided cardiac surgery. All the other indications are 2As, and you can see here that for isolated TR, again, no class 1 rec, it's a 2A, but the level of evidence for that recommendations is a C. In other words, it's just a bunch of anecdotes. And so we really don't have good consensus as to when and how to treat these patients with TR. And when you look at these patients, they do really poorly because of that neglect and the lack of science and understanding of how and when to intervene. If you look at this study from Mayo Clinic, now a couple years old, 10-year survival in a community population of TR is 14%. I mean, that's horrible. I mean, that's just, 90% of these patients are dead within 10 years. And it doesn't matter whether the TR is in the context of other etiologies or if it's isolated, these patients do really poorly. So what's really exciting, though, is, you know, we can talk now about how that science of TR is going to change. And I'm going to spend the next several minutes talking about how transcath therapy could affect this population and improve their long-term survival. And when you think about TR, you know, like all other valve disease, our goal is to try to repair and try to restore and recreate that coaptation between the leaflets. And looking at the tricuspid valve, and these are beautiful images. Richard came in just a little while ago, and these are beautiful images that Richard's helped lead us get here in our echo lab. You know, we think of the tricuspid valve as 3 parts, 3 segments, but it's so much more than that. It can be 3 segments, like up here with a commissure that runs north-south. It can be multi-segmented here. Sometimes it's 4, 5, 6 leaflets. Sometimes it's 4, 5, 6 segments. You can have 2 posterior, 2 anterior, 2 septal. You can have all of the above. There was a paper we published on that description, really highly prevalent complex anatomy. You can have coaptation planes that run north, south, east, west here. And then you can have something where there's simply no coaptation. You can drive a truck through this tricuspid valve. And so it's incredibly varied, and it's so much more complex than just a few leaflets that we're trying to put back together. Now, the prototypical device for repair is a TriClip. And this is the device that likely will be commercial within a year, and will be the first commercially available device in our practice in the United States before any other. It's like the mitral clip device in that it has some of the same features, but it's specifically designed for a tricuspid valve because it has a different set of curves. It's got a different set of knobs. And essentially what that does is it allows us to steer in the right atrium in a small space and get to all the points of the tricuspid valve to address all those different coaptation planes that are running in multiple different directions. And you can imagine that we need to do this with all of these knobs, and we have at least 8 steering ways to do that, and that's really important around that complex tricuspid valve. So here are images that Richard took in one of our cases. You can see this is the what we call the clip delivery system, or CDS, which is coming up the IVC into the right atrium. We steer down towards the tricuspid valve, as one can see here. And an interesting note here is that look how long this sleeve is. So this sleeve stretches out 6 centimeters. So when you see it that long, and you can see the markers here, each of these is a centimeter, this right atrium in this patient is huge. It's absolutely huge. And it's also horizontal. And so if you see that coming straight across here, it's a horizontal heart, which provides its own challenges. Here's this transgastric view, which we use to align the clip arms perpendicular to the coaptation plane. And then here we grab the anterior septal leaflets with the device. I heard this described on Saturday as like grabbing a bouquet of flowers, which is actually kind of interesting. And then we do it again. There's a second clip here, posterior to that. And then one can see here the TR is really quite mild when we're done in this RV inflow view. And importantly, it's a very safe procedure. So in the early feasibility study, which we published in the Lancet, 97 patients, not a single 30-day mortality, stroke, cardiac surgery at 30 days. And so as a right-sided procedure, it's very, very safe. And that's an important part when you think about the future of TR therapy. So you can see here, so this is one of those moments. So this is the first Triluminate case that was enrolled in the study, and this was the first case with the new system. And again, I'll point out Richard here has been absolutely instrumental in helping us get this going. I have Richard, I have Kate, our STAR coordinator, Joao Cavalcante in the back here, and the entire team. Very proud moment for MHI and MHIF. And the trial is really enrolling really well, and likely will be finished enrollment either this summer or this fall. And so I have the pleasure of doing this with David Adams out of New York. And the Triluminate trial, for those of you who may not know, is enrolling patients who are intermediate or greater surgical risk for TR, and they have to be anatomically eligible on guideline-directed medical therapy. We then do an assessment, and we decide what's the likelihood of getting this patient to moderate or less with the TriClip device. If it's high, we put them in the randomized arm, in which patients are randomized between TriClip and medical therapy. If the pathology is more extreme, in which we think, well, we can get TR reduction, but it probably won't get to moderate or less, they go into the single-arm cohort where everybody gets TriClip. And the one-year primary endpoint as you can see here. We also have a 2-year secondary endpoint, and we'll be extending the study out to 5 years and follow-up for these patients. And it's enrolling really well, and we should be finished probably this year. And to give you an example, we're here at MHI, very friendly environment, so this is an opportunity to brag about what we've done as a practice. So here, this is last week's Enrollment Leaderboard, and you can see here all the sites, and these are the top valve sites in the United States, Canada, as well as Europe. And I'm just going to enlarge this for you. If you look here, look who's on top. And it's really amazing. We're twice that of second place. And if you look at this list, again, this is a who's who of the top centers in the world. And this is absolutely incredible work. Lisa's here, Richard's here, Kristen as well. The MHI and MHIF partnership is it's world class. It's unbeatable. And I tell you, every week when this comes out, it's just a little perk. And if you ever want to just see it yourself. We'll send it to you. They sent out this newsletter. It's just kind of like, well, that makes my day. And so I'm really, really proud of how we've done in this trial. And just to think about, for the first pivotal TR trial, we will have enrolled probably 1 in every 6 patients for that trial. It's just absolutely incredible. And that leadership extends across multiple disciplines. So for those of you who may not know, Joao Cavalcante and MHIF was given the first core lab for a TR pivotal clinical trial for CT-MRI last fall. First ever. And this is groundbreaking. And the reason why is because Joao has pioneered this amazing imaging. Look, here on the left side, this is what can be done now. This is so John and Joao's work here. So here, look at this MRI. Look at this RV end-diastolic volume, 237, regurgitant volume 86, RV diameter of 50. We do some clips in them, and you can't see the clips, and you get this blooming artifact here. But just within 30 days, look at the RV volume change. It goes from 237 to 166. The regurgitant volume goes from 86 to 2. I mean, John, can we really quantify 2 mLs? Absolutely. There you have it. I mean, how can you? I can't even measure that in my bottle here. I mean, this is 2 mLs. It's incredible. And the RV already shrinks. This is just 30 days. It's really just amazing. And this patient is doing amazingly well. And so this is the groundbreaking stuff. We now have enrolled 60 patients in the imaging sub-study for Triluminate. And Joao and John, I mean, just hats off to you guys. So Triluminate is obviously the major focus in the TR world right now. It's got the most experience, but there's some other technologies that are also coming your way, and I just want to make sure those are covered as well. The Pascal device is the Edwards version of MitraClip. It's also a TEER device, edge-to-edge repair. Here, this is a nice example of elimination of TR, but just like Triluminate, no death, stroke, bleeding, or adverse events at 30 days. Again, right-sided procedure, very, very safe, and good elimination of TR. And this is a fast follower in terms of edge-to-edge repair for the clinical trials. Now, instead of repairing, we also have replacement options, and the leading replacement device is the Evoke device. This is made by Edwards. Hundreds of patients have already been treated worldwide. Sushil Kodali presented this last fall at TCT. Success rate's almost 100%, takes about an hour and a half. Patients can essentially go home in a couple days, very low mortality. And the amazing thing about replacement is that it's relatively agnostic to the tricuspid valve anatomy. In other words, pretty much everyone gets elimination of TR. We have to decide living with the prosthesis is worth it or not, but certainly the results are amazing. Here at MHI, we have 2 tricuspid valve replacement technologies that we've been working with. Medtronic's Intrepid valve. This is the same valve that's used in the Apollo mitral study. It's 42 to 48, but soon will be available in up to 52 millimeter. It's a 27 millimeter double frame valve, and it goes through a 32 to 42 French venous system. Currently, we cut down to put it in, but just look at what this can do. So here in the top middle, look at this valve. I mean, this valve is in pieces. The coaptation planes, it's a starburst, compared to what I showed you earlier. Multiple different directions. I wouldn't even know where to start to put this valve together, and basically we just wouldn't. So here, Vinny Bapat, cut down, and he and I then inserted and steered this valve towards the tricuspid valve. These are beautiful images that Richard got, nice MPR and elimination of the TR. And Vinny is the national PI for Intrepid EFS, along with Azim Lateeb. So again, another great example of MHI leadership nationwide. And this study is continuing to ongo here in the United States. The other example of TVR is the V-Dyne valve. And this is an interesting valve. This is made by the same people who made Tendyne, which I know all of you are familiar with. It's a double frame valve. And the nice thing about this is that the outer frame is more oval. And essentially, if you remember back to our school days, we were taught that the left ventricle is kind of a donut and the right ventricle is kind of a croissant. And so this is designed to fit the croissant. And it's designed to not over distend the RV, which is very sensitive to distension. And it goes through a very low profile system, 28 French, 30 millimeter valve, and it treats very large right ventricles. And this is an example of the first in human case that we did and got a really nice result. It was a bit of a struggle though, because the delivery system was still in development. And unfortunately, this patient had a wire exit and caused pulmonary hemorrhage and died after struggling. But this at least demonstrates the feasibility of this technology. And I have the pleasure of leading this study with Mike Reardon out of Houston. So we'll see where this goes in terms of future therapy. But I think my take home, and this is where I would really ask you to get excited about the future, is that what transcatheter therapy for TR really allows is it allows us to examine the science of TR in ways that we just have not been able to examine before. So remember, a lot of the history of TR has been anecdotes, surgical series, and what have you. But what transcatheter therapy does is it allows to examine TR and what we do in randomized controlled trials. And that's what's really, really exciting. Triluminate is the first RCT, but it will not be the last. We're testing the impact of TR reduction. It's the excellent safety that allows us to randomize these patients. We're doing things like right heart caths in all of our patients to make sure it's the TR we're after. We don't want left-sided disease or extreme pulmonary hypertension. But we're also including a broad range of patients, so intermediate or greater surgical risk, PA pressures up to 70, EFs as low as 20, and John was going to talk about pacemaker leads. We put patients with pacemaker leads in the study if needed. The other opportunity that TR in the transcatheter world really offers is it offers new clinical pathways. So we're quantitating TR in ways that we just haven't been quantitating before, and I apologize to Richard, who gets the headaches of this. When we ask for the PISA and it's not there, or the vena contractor it's not there, but Richard's been amazing in supporting this. And it's much more than just looking at the color. We have developed new ways of describing the tricuspid valve. So these are RV inflow views, and this is a sweep of the bicommissural plane. And this is beautiful transgastric views to look at the gaps in MPR. So these are all come about because of the Triluminate trial. I didn't even know what this view was until just 3 years ago. I had no idea what they were talking about. There's also opportunities for new treatments. And so if you look at some of the older surgical literature from 2000 to 2013, so on the left-hand side, this is STS database. On the right-hand side, this is a national inpatient sample. And you can see that things have generally gotten better, but they still are at significant risk with a 30-day mortality that is anywhere from 8 to 13%. And certainly, most recently, there have been a few series in expert centers that have shown that that can be better. But nationwide, these patients can be at high surgical risk. And so we're offering a therapy that's very safe for these high-risk patients. And just a few more opportunities. We're also defining what is meaningful. And so we're very used to describing things as mild, moderate, severe. But with TR, it's actually mild, moderate, severe, and massive and torrential. And that's because in some of the early data, But what we found is that, first of all, there are a lot of patients that go beyond severe. And then the other aspect of it is what we found is that any 1 grade reduction, it leads to an improvement in quality of life. You go from 5 to 4, 4 to 3, or 5 to 3, even though it's still severe, the KCCQ score on average is plus 15. And so it's really quite meaningful. And so we're going to find out if that EFS data holds up in a randomized trial for TR. And these patients are out there. I mean, look at this valve. I mean, we are seeing stuff that we have just never seen before. It's everywhere. And I'll tell you, we do need something much more than just saying it's severe. And this is why. And finally, 2 more opportunities I just want to talk about. And so Triluminate, we have this imaging sub-study, and Joao is leading this, and we're doing CT, MRI, and TE and transthoracic on all our patients at baseline and follow-up, and we're comparing all the methods for quantitation at baseline and also the changes. We're measuring RVs and tricuspid valves unlike ever before, and we're learning a lot. And this trial is designed and powered for superiority. We're trying to see if what we do with TriClip or these percutaneous methods improves upon current practice. And the randomized arm has meaningful endpoints, and the non-randomized arm as well. And we're going to understand what that TR reduction does to those endpoints. And these endpoints, honestly, they were very hard to pick when we were setting this trial and the protocol up. And we did our best, and we'll see if we hit the mark in terms of the endpoints. So in my summary, the key points I ask you to keep in mind is that we are addressing a high-risk, neglected condition. We have new clinical pathways that are being established. We have more insight that we're gaining into the impact of what we do in survival and quality of life, and we're setting the stage in terms of benchmarks for future studies. And it really is an exciting time. MHI and the foundation has been just absolutely just killing it. And I tell you, the team we have here, Lisa, Kristen, we have Richard and Joao, I know, and many people in our practice, just absolutely leading the world. Here's in the picture from TCT. I think, Marcus, is that you? I think that is you there. Yeah, there's Marcus, Vinny, Joao. Richard was on the other side of this table. But we have multiple national PIs in multiple studies. We have top enrollments. We had the first CT, MRI core lab for a pivotal TR trial, and now we have multiple FIHs. And so I can't thank you enough for all the support that you guys have done. It's been amazing, and it's even more exciting when we think about the future. So at this point, I'll turn it over to John. He's the other half of the John and Paul show, and we'll go from there.
Let me see if I can put this on. Paul, for a neglected valve, you sure do have a lot of new toys. We still just have wires. I got it. Okay, I think I'm good. All right, now I got to figure this out. All right. There you go. Well, I'm John Zakaib. I really appreciate the opportunity to be here with you and to share the podium with Paul to talk about this topic, which I, must admit, I feel like the tricuspid valve has always been an obstacle for us to traverse, getting where we need to go. And like Paul, I mean, I think it's just an emerging realization that there's a lot more to the tricuspid valve and managing TR than what we ever recognized before. So I appreciate the opportunity to be with you today and talk about a small subset of the patients that Paul takes care of. And those are patients who have device leads crossing the tricuspid valve or other EP devices that may be impinging upon tricuspid valve function. And I wanted to just run through some salient anatomy mechanisms of lead-related tricuspid valve regurgitation. talk a little bit about the evolution of indications for lead extraction where tricuspid regurgitation is concerned. Because as you saw, there's as few indications for tricuspid intervention there are, and those are emerging. Indications for extraction don't touch upon tricuspid regurgitation or tricuspid valve intervention. It's just not part of the lexicon of extraction thus far, but that's an emerging thing. And then some technical and procedural elements of lead extraction that we have to consider when we look at these relatively higher risk patients who are high risk for cardiac surgery. Certainly they have increased risk for extraction as well. And then we'll look at some alternatives and technologies that are allowing us to try to mitigate risk for development of tricuspid regurgitation. Sorry, this is a busy slide. So it won't be the last busy slide. I did a talk about anatomy for the electrophysiologist, and it's an amazing way of considering the anatomy of the heart, because when, as Paul well knows, some of this anatomy you learn in medical school, and it's two-dimensional, it's on paper. But when you're working inside the beating heart, you have to be cognizant of where you are, what's in front of you, what's adjacent to you, what's behind you. And you take on a really perspective of working, of actually being in the chamber you're working in and working with these structures that are functional around you while you're working. And so obviously you can't take in too much from this slide, but from the standpoint of extraction, we're working on, if you can see the mouse pointer here, we're working with this venous anatomy, which is often congested in the setting of severe TR, and it's often compromised in terms of luminal diameter or even occluded in the setting of chronic pacing leads. And so there's a lot here for reference, but that's the important message. And working in the right atrium, obviously a complex structure, which in the normal case, there's a lot of anatomic structures to be mindful of, both functional and electrical. And then, of course, in the abnormal case, as the anatomy that Paul was showing you with a 237 milliliter atrium, everything is distorted. After surgery, things are distorted. So all of these things you have to be able to adapt to as you work within the chamber. Here's a right ventricular view. I love these Netter drawings because they just kind of crystallize the complexity without overdoing it. These valve leaflets is the tricuspid valve from the atrial side, and you can see this anterolateral is usually the largest leaflet. I don't know how to go back here. The septal leaflet in this view, this is a supine view, but that septal leaflet is one that often gets compromised by leads traversing the valve, and the posterolateral leaflet can get pinned by leads crossing the valve. So the valve has always been something that we just have to cross to get to the right ventricle so we can pace. And it's always been done with fluoroscopy, and we don't consider the valve. We can't even see the valve. We can see the annulus. And so there are a variety of ways that our pacing leads can entrap or can otherwise cause tricuspid valve dysfunction. This is from David Bendit in 1991 at the university. Interesting little drawings here. Entrapment of the septal leaflet by the lead body just as it crosses the valve and it goes into the septum. I mean, it's just mechanically pinning that valve open. And then as the lead becomes resident for years and years, there's potential for fibrotic adhesions with valve leaflets that can cause tethering of those valve leaflets. There are times when if you just advance a lead into the atrium and bump up over the eustachian valve, and then you're in the ventricle, you could have perforated one of those leaflets and not known about it. And restricted its movement, much less caused a tear or some other compromise. And finally, the subvalvular apparatus that you saw here, it can get tangled and even disrupted by the presence of leads, especially ICD leads and other hardware that we put in the right ventricle. So there's lots of potential for mayhem when you're crossing these leads with valves. And here's just a side light, tricuspid valve surgery has been done, and at times entrapping leads with the valve ring, which is a big problem for us because, for 35 million cycles a year, a metal valve ring rubbing against a silicone lead insulation can cause dysfunction, can break the insulation, can fracture the conductor cable. And once it's entrapped like that, we can't get it out percutaneously. So we have to kind of plan these interventions and make sure we don't end up causing mayhem in these situations. So this is a guideline document from 2017 talking about, well, when should we take leads out? And in the setting of severe TR, the guideline document says, well, if there is severe TR, and Paul gave you a little bit more information about delineating the definition of severe, and an intervention is planned, and there's right ventricular enlargement and dysfunction, or there's not a permanent change in right ventricular dynamics. If the annulus is not too dilated, there's all these caveats about whether we should do something, and of course, all of that is changing. And so the guidelines aren't helping us really make these decisions. And in a lot of cases, the patient who has leads are dependent on the leads. They're dependent for pacing, and so we have to be able to have an alternative strategy for pacing them if we're going to consider removing functional leads to pursue a percutaneous approach to management of their leads. And in this situation, where I can show you this here's an image of some tricuspid regurgitation, and there's a lead crossing the valve there, but it is not causing the regurgitant problem. It's just there. And so we kind of have this situation where sometimes people have functional leads, and the lead's not causing the problem, but they do have a problem that we need to intervene upon, and so we got to get that lead out of the way. So facilitating a percutaneous intervention, even with a functional lead, is becoming an indication. Well, what about extraction? We call it removal if the lead is less than a year old and it's just going to come out with simple traction. And so that's less of a concern. Extraction is a complex procedure that's done under general anesthesia with a team of people, perfusion and cardiac surgical backup, sometimes with our imaging colleagues. Often anesthesia will do our transesophageal echocardiography for us while we're working. And we use a variety of tools that are very aggressive to disrupt fibrotic adhesions, occlusions that may be restricting our ability to remove leads. And the leads we've implanted over the years, especially dual coil ICD leads, and even single coil ICD leads, tend to promote fibrosis, and they get socked in pretty well. And so when we see a person who has had a lead for 20 years, and they haven't had TR for 20 years, but they're developing TR, and now the TR is sufficient to warrant intervention, and we have to take out a 20-year-old ICD lead, we've got a fight on our hands. So we perform the procedure in the EP lab, and we prepare the patient for cardiac surgery. We have all the perfusion support in the room, and we bring a lot of equipment into these rooms, and it's pretty cramped in there with the laser system as well as the operative equipment. We do it with operative TEE. We have femoral, venous, and arterial access so that we can pace, that we can occlude the SVC with a big hot dog-shaped balloon if we need it to mitigate hemorrhage if we have a tear while we're trying to get the chest open. Arterial pressure monitoring, volume resuscitation, and even cannulation. And ultimately, it's very important to consider extraction as a high-risk procedure. I mean, the consequence of a complication is severe. It's open heart surgery. It's emergent open heart surgery, and people can die. So we have to take it very seriously. The mortality in larger studies looking at high-volume centers is 1% or less. It's 4% 30-day mortality if the indication was endocarditis. So if the person is really sick, it becomes an even higher risk thing to do. And looking at a study from my former mentor in Cleveland, Dr. Wilkoff, the chance of damaging the tricuspid valve, I mean shredding it with the laser system, extraction system, is about 10–11%. So, and this is a three-dimensional TE image here that shows a flailing tricuspid valve leaflet after extraction. So, you know, we extract for lead dysfunction, fracture, insulation break. We extract for a venous occlusion to upgrade systems. We extract for infection. And now we extract to get our leads out of the way to facilitate tricuspid intervention. And as a result of that, you know, we're really modifying the way we implant. And hopefully those changes will all be synergistic in the future. So what I've showed you here is a large field fluoroscopic image of our laser system tracking down this dual coil ICD lead. You can see there's a lead-lead interaction. These leads are fibrosed to each other. We're about to go through the danger zone here, the superior vena cava, where our laser system's going to track along, and I'll show you how that works. And then, you know, we have multiple leads crossing the tricuspid valve here. Here's an old pacing lead. This person was dependent, and then they developed worsening function. Obviously, they got an ICD lead there as well. So we've got a complex extraction going here. What I'll show you is these are images of the tools that we use. This is a mechanical rotating blade sheath. And you can see in the center there, this rotating bread knife type of serrated blade spins 270 degrees forward and then back every time you actuate this large grip, you know, like a grip exerciser. And it's actually torture to use this thing because you're going to cut a ½ millimeter forward at a time, and it could take you 200 cuts, 200 squeezes of this thing to get down one lead. So whoever created this didn't really understand the nature of the fibrosis that we're cutting, but they walk right through it with this device. I wish it were this simple. But you can see here on the left there, they're traversing the subclavian vein. They cross the innominate there, and then here we are in the SVC. And this is a mechanical rotating blade sheath. It's very effective for certain types of fibrotic lesions, calcified lesions. And then the laser sheath is the other important tool that we use. And this is a flexible excimer laser sheath. It's 14 or 16 French, and then we use an outer sheath over it to get it up to about 20 French. So it's a large system, a little bit stiffer and a little with those telescoping sheaths, and certainly there's risk, especially on the right there where you're traversing dense fibrosis in the superior vena cava, that you could have a tear in the vena cava, which would result in catastrophic bleeding. So it's a little higher risk through the SVC than the mechanical solution that is only doing its cutting inside the sheath. This is cutting 1 to 2 millimeters in front of the sheath as you track down the lead. But ultimately, it has a higher success rate with extraction. So a little gross specimen for you. This is leads that have been extracted These are pacing leads. Here on the left, you can see there's a lot of fibrotic debris that comes out with the lead. And some of that, especially here on the right, you can see here's the tip where the lead was implanted in the right ventricle. This was fibrosed to probably subvalvular apparatus. This is probably a piece of the tricuspid valve. This would have been draped across the valve. And this would have been tissue that was fibrosed in the SVC. So if the person had all that inside and now it's outside, you know, you worry when you do this procedure that you could create a hole. And it's a harrowing procedure to perform at times. Well, I'll give you a little bit of a conundrum here. We have a patient that we saw from the West who was a cowboy. He was kicked in the chest by a cow and developed symptoms thereafter. And he turned out he had a pulmonic stenosis, congenital pulmonic stenosis, had multiple surgeries, had an ASD closure years ago, and then had some mild dysfunction and had permanent atrial fibrillation after multiple interventions, several over the past decade. And ultimately, because of ventricular dysfunction and permanent AFib, he underwent implantation of a biventricular ICD system and an AV node ablation. So now he has permanent heart block, and he's dependent on that device for pacing. But he develops severe mitral regurgitation, which Dr. Sorajja discovered at the time of an office visit, and he got admitted and got his mitral valve repaired. And then the tricuspid regurgitation needs to be fixed, but he's got that ICD lead in the way. Now that lead was only 6 years old, but it was fibrosed in, and we had to extract it to get it out of the way for a planned intervention. And he had all the classic symptoms of severe, more massive tricuspid regurgitation. So we took the lead out, and I won't, get too into the extraction technique. That lead came out, but we have to be able to pace because he has LV dysfunction, and we can't cross that tricuspid valve because there's a planned intervention. So we did an injection here of the middle cardiac vein to see, hey, could we find a septal perforator that goes up into the septum? We could get a lead into that. Didn't have a good septal perforator, so we went to the anterior cardiac vein. He already has a lateral transvenous device for a lead for CRT, so we just need one more lead to achieve biventricular pacing. So we end up putting a pacing lead, a bipolar lead in the anterior cardiac vein. And so after managing the extraction to facilitate the tricuspid intervention, we still have the problem of we've got LV dysfunction and we need biventricular pacing, so we had to come up with a sort of MacGyver solution to manage that problem, which actually worked out just fine. He's got apical anterior cardiac vein pacing and posterolateral LV pacing. So from the CRT standpoint, we're doing pretty well. But what could we do in the future to mitigate the problem of lead-related tricuspid regurgitation or leads crossing the valve that might be in the way of those types of interventions? And I'll just share with you these devices. Paul, maybe you could pass these around so people can compare. The LEADER trial, which we're running here at MHI through the foundation, this is a Medtronic-sponsored trial of the next generation ICD lead. This is a 4.7 French ICD lead. That's a single coil lead, much smaller diameter, 1.5 millimeter diameter. It should cause a lot less tricuspid regurgitation because it's so small and floppy that the valve can push it out of the way and push it into a commissure so that it doesn't end up contributing to that problem. It's delivered by a sheath instead of just randomly by a stylet into the right ventricle, and so we can direct it directly into the septum and embed it in the septum so it really sticks horizontal or perpendicular out of the septum and then flops back. And you can see in this image, there's a nice curve to it. All of that radiodense segment is the shocking coil. All of that, that's 6 centimeters, is in the ventricle. And then the very floppy segment of lead traverses the valve. It's a very robust, very simple lead, and we're enrolling in that trial right now. Here's a picture of the lead in comparison to a standard 9 French Medtronic Quattro lead above the lead, and then there's an Apple cable. I'm passing around the leads right now. If anyone needs a charging cable, I could pass that around also. But much less likely to cause a vascular occlusion. And then at the bottom of that picture is the Micra leadless pacemaker. This is a 4 French pacing lead that is, again, much smaller and very robust pacing lead that we're using to traverse the tricuspid valve. Now, in comparison to the atrial lead, which is pointing straight upwards there, which is a standard 5076 lead that's been used for the past 30 years. But smaller and compliant, floppy, much less likely to contribute to this problem. And then here's the Micra, and Paul and I were talking about the complexities with Micra and all of that subvalvular anatomy that we experience. And we have a very simple single curve, large 22 French sheath that we use to deliver this pacing device. And it's a way of single chamber pacing in the right ventricle without crossing that valve. But as Paul was saying, the anatomy is much more complex than just 3 leaflets. And so we're finding that, hey, there can be actual impingement of the valve, restriction of those leaflets with Micra, just because of the size of the device and the fact that we've just embedded it, within the papillary muscles and the chordae. So more to come with this topic as these things evolve. It's been a pleasure. I'm happy to take questions, but we got to review some anatomy. We got to talk about extraction a little bit. You got to see some cool videos and gross specimens. I'm sorry about that this morning. And then just don't forget that patients who need ICD leads may have this option. Even at MHI, we're going to implant 50 here. We've already implanted 4 and had great success with it. So we'll see what the future holds for this collaboration, but I appreciate the opportunity to be a part of it. Thank you.
Is this mic on? Yeah? How's that? Good. There's a button on it. Button? Yeah. Perfect. All right. Well, thanks, John. And so we have a few minutes here, and we'll just happy to take any questions. I hope you enjoyed that overview of TR. Questions from anyone? Perfect. We'll let you go ahead.
Yes. So in preparing to identify which patient for what, as well as for pacing, is there any value, and how do you see the use of imaging to help you identify who's what, and maybe you can explain what we do?
Yeah. So it's a good question. So, if a patient presents with TR and we're considering some type of TR intervention, it's always, okay, what? And so, and we always consider, well, if we could repair, that's great. If not, then we have to consider replacement. So we'll get the T, we'll look at the lead interaction, look at the lead positioning, look at the amount of leaflet redundancy there is, whether or not there's leaflet injury or severe tethering, and we'll come up with an idea of how feasible it would be to do tri-clip or some sort of repair. But we don't stop there because we have to essentially assume for the possibility, as great as John is, even if it's small, of the risk of the TR getting worse to where it cannot be repaired. And so that it's just going to happen. John said 10%. That's plenty of patients in whom we send for extraction, and then unfortunately we can't repair afterwards. And so then the next step then is always to get a CT scan, because the CT will tell us about sizing for replacement. And if the CT suggests that we can do Intrepid or V-Dyne or something in the event that we can't repair, it helps me feel really much better about sending the patient for extraction, because then we have a fail-safe mechanism for that. Does that make sense, John?
It does, yeah. I would say that that when we have patients that are moderate to high risk for cardiac surgery, and we've decided, well, we're going to try to do a percutaneous intervention, you know, those patients are high risk for extraction. And so all the imaging that gets done, the CT scan, we cheat and look at every imaging study that's available to try to figure out what problems we're going to encounter, what equipment we'll need, and what our likelihood of success is going to be. And there's some more complexity with the different leads because some are more easily extractable than others. People have dual coil ICD leads or single coil ICD leads. There's a lot of complexity to some of that decision making, but ultimately, if the lead needs to come out, we've got a high success rate getting them out safely, and we just have to support our patients through it. I'm jealous of all the imaging that's available to you all.
Well, so I was going to ask you, so is there imaging that's helpful for you in terms of mitigating that SCC risk, you know, in terms of adhesions and such? I mean, do you look at the CT scan, look at thickness, adhesions? I mean, how do you measure or estimate that risk to the patient?
It's really difficult. I mean, I look at the CT scan to try to make myself feel better, but we're going to go there and we're going to take that lead out regardless. And so it doesn't really matter. The scan, because of, especially with SVC coils, there's blooming on CT scans, and you never get a reassuring feeling looking at the scan, but you know that lead was inside the vein when it was implanted. And so fibrosis that forms there, you know, is luminal, and as you extract it, it's a technique of traction and counterforce to try to make sure that you're only cutting fibrosis as you traverse. So the imaging is very helpful to see, okay, what kind of lead interactions are there, and whatnot. But ultimately, the risk is what it is, and if the lead needs to come out, it just needs to come out.
I was going to suggest T, but sometimes the SVC is quite hard to see.
It is.
What about ice? Have you thought about ice?
We tend not to use ice because it doesn't add a lot in terms of clinical decision making during the case, and it adds a lot of cost, and it puts another, you got to have another access, and it puts another piece of hardware in the right atrium. So we tend to rely on we use a stiff Amplatz wire, and we have a bridge balloon system. This is a long balloon that we can inflate if we have a catastrophic bleeding. Occlude the SVC, which buys about 20-30 minutes to get on pump and get the chest open. So really the risk management is risk in mitigating a catastrophe rather than using imaging up front to determine whether you'll be able to extract.
Yes.
Dr. Sorajja, can you touch on the importance of assessment of RV function and how that then plays into your patient selection and device selection in terms of tricuspid intervention?
It's a great question, and it's a great unknown, to be honest. We had one patient who struggled after triclip, and it turned out that patient, and she needed dobutamine after we relieved her TR, and that patient turned out to have amyloid. And so it's interesting, but the other patients, in terms of RV size and such, because it's a relatively safe procedure, we don't completely cut off the TR, it's usually very well tolerated. The one watch out, I would say, as a clinician, is when we do the right heart cath, if the RA pressure is really high, I get really worried about those patients and how they do, because there's a lot of spatial limitation to RV assessment with our current methods. But the imaging sub-study with traumatic CT and MRI, that's going to give us a lot of information about that going forward. Right now, there's actually no RV exclusion for triclip, believe it or not. So we'll see how that is. Yeah. John?
Just anecdotally, it's very unusual, torrential TR, to have RV dysfunction that's significant visually or measured because of the TR.
And the RV is, again, it's usually a late phenomenon. If there's severe RV dysfunction with severe TR, it's actually the minority of patients, and usually they're hospice already. So
Yeah, John, any questions online or? Perfect. All right, we'll give you back your Monday. Thanks so much for
Great,
coming.
thank you.